Right, hello everybody. If you want to move forward, you can, but if you don't want to, you don't have to. Okay.
Move back if you like.
Yeah, if you like. My name's Gwen Moulster. I'm a consultant nurse in Harrogate, London.
And I'm Dave Atkinson, and I'm an independent consultant nurse. I'm kind of here, there, and everywhere. But I also do a couple of days a week as a consultant nurse with Dansha.
So he's not going to sing, you know, they're here, there, and everywhere.
No.
Okay, so we've got a few minor technology problems. We did have a video to show you, but we think it may not work. So when we get to that bit, we're going to have to just tell you the story. Dave's going to sing. He did say he should have brought his ukulele, but he didn't. So you've got the dibber, not me.
Do you want me to start?
Yeah, you can start.
Okay, so we're going to tell you about the Health Equalities framework. I'm kind of wondering, has anyone here, stick your hand up if you've heard us talk about this before? Just so we don't feel, oh God, quite a lot of people. Well, we're going to, quite a number of people, so we're going to try, well, we were going to try to do something quite different. The intention was we give you a real quick sort of run through the background, rather than doing all the sort of researchy stuff. We just sort of kind of what it is and how it might be used, and we did have some lovely video clips which we now no longer have, so Gwen is going to perform. No, she's going to describe the bits that would have been... Gwen, unfortunately, due to the technical hitch, is going to have to describe the bits that unfortunately we can't play for you, and hopefully it'll still make sense, and we'll give you a little demonstration. So it's kind of, today's more about the HEF in practice. So a little bit about where it came from, if I can get the thing to work. Very good. So what is it? What is the Health Equalities framework? It looks like some people already heard about it. Essentially, it's an evidence-based outcomes framework. So where's the evidence base come from? It comes largely from the research that was published by IHAL, the Public Health Observatory, who spent a lot of time and a number of reports over recent years describing the health inequalities that are experienced by people with learning disabilities. They also have reports that tell us about some of the gaps that exist in the sort of data and information set relating to people with learning disabilities. So we were very fortunate in this piece of work that someone else had kind of done all the evidence-based bits. So what we endeavoured to do was to pick up that evidence and to start thinking at its core, what is it that learning disability nursing is about? How do we demonstrate what we do? How do we demonstrate that we're a profession that's worth investing in? We recognised that there was probably an absence of good, effective tools by which to demonstrate our outcomes, and people may have seen some other outcomes measures about things like HONOS, ECOS, various things, which I think generally most nurses feel don't necessarily get to the core of what nursing is about. So it was systematically developed, and how did we go about that? It's kind of a 2-year process really of development, during which there were a range of pilot exercises, a range of consultation exercises with nurses and with other allied health professionals and medical colleagues as well. So essentially the HEF is about measuring the contribution of learning disability nurses, and as the project progressed we realised it had broader applicability to other groups, so other professions as well, in terms of reducing the exposure of people with learning disabilities to those known determinants of health inequality which the Public Health Observatory had described for us. So that's kind of what it is. There's a number of different bits and pieces that go with it. So first of all we have the EHEF. It's an electronic tool that allows us to chart and profile our service users' exposure to the inequalities, to the determinants of health inequalities, and therefore over time to track what difference we as nurses make. We then have a separate tool, the HEF Manager, and what the HEF Manager does is it kind of links with the EHEF spreadsheets that potentially could be dotted about on different teams' network drives, and it kind of sucks out anonymised data, so it strips out all the personal identifiable details and allows us to work with large quantities of aggregated data. So it means that we can start to understand how one team performs in terms of outcomes in comparison with another, whether people with learning disabilities in one city achieve similar or different outcomes than another city. So essentially it allows us to work with very large quantities of aggregated data, and we're going to show you those in a short while. There's a suite of tools that we produce to go along with that. So obviously there's a guide to how the Health Equalities framework works. So we have something that services and practitioners can make use of. We then also did some work with the National Development Team for Inclusion, brought them on board as partners, specifically really around developing a guide for commissioners. So what we were able to do was to demonstrate how good quality data that's generated by the HEF can help to inform good commissioning decisions and can help commissioners to evaluate the quality and effectiveness of the services that they're buying. We produce an accessible service users guide for the health qualities framework and also a carers guide as well. So that's the kind of what is it. Okay, so why do we need it? And I guess that you know, people in this room are likely to know all this stuff to start with. First of all, we know that nurses work in all sorts of settings these days, everywhere from forensic services to acute hospitals, primary care, assessment and treatment units, supported accommodation, advocacy. So nurses are working in all sorts of different places with widely kind of discrepant service models. So there's a bit of a sort of challenge there about how do we have an outcome measure that's applicable to core roles and core functions of learning disability nurses across all of those settings. I've already mentioned the fact that, you know, we know that there's no national data set that relates specifically to the health of people with learning disabilities. There's lots of data about our service users flying around the midst of all manner of information systems, but to pluck out the bits that are specifically related to people with learning disabilities and to remove that from general population data is very difficult. So there is no kind of overarching data set. We know that there's overwhelming evidence of inequalities. We know the confidential inquiry tells us that people die early. We've got death by indifference. We've got so many documents in recent years that tell us that people with learning disabilities have far worse health outcomes than the general population. And of course, we've also got information that tells us, and particularly I'm thinking again of the confidential inquiry, which I'm not going to go into great detail about. If you haven't read it, read it. But we know that some of these adverse health outcomes are to some degree avoidable. And I guess that's what learning disability nurses really should be focusing on. We know that commissioners have a great deal of pressure on them to deliver value for money. Money is tight. They need to be able to demonstrate the efficacy of the services that they're commissioning. We know that in terms of public health, that there are again some real sort of challenges. We have a significant population group who are marginalised, who have much poorer outcomes, and clearly there's a role for sort of public health strategy to try and address that at a population level. So it's not just that we therefore need information and outcomes monitoring at an individual service level, user level, but also at a population level. So we were kind of wanting to develop a system that would work at both levels. So we could look at what goes on for an individual nurse or an individual service user, or what goes on for a team or for a much broader population. So hopefully we've come up with something that will meet those requirements. We know that we've got challenging demographics. We know that the numbers of people with learning disabilities are increasing. We know that the complexity of their needs is increasing at a time when, you know, as I've already said, there are great financial pressures. So we need to be able to assure ourselves, as much as anyone else, that the things that we're doing are genuinely efficient. We're keen to recognise that within all manner of sort of policy frameworks, that there's a great focus now on looking at outcomes rather than process. So I guess if we were thinking of an acute hospital, it's kind of not about how many operations do you perform a week, but, you know, does the patient live? And in the same way, in terms of learning disabilities, it's not about showing how busy we are, how much process we do in the space of a week, but are we generating some positive outcomes as a consequence of that? So essentially what we wanted to do was to make sure that learning disability nurses and nursing is judged on its best, not on some of its poorer and poorest examples which have been played out in the media over recent years, but, you know, kind of judges on the best of what we do. So what we want to do, hopefully, is have something that shows the difference that learning disability nursing can make. So how does it work? We're going to demonstrate in a moment, but essentially what it does is it enables us to build a profile which demonstrates that people's exposure to known determinants of health inequality. The evidence base readily tells us that there are 5 significant areas of determinants. We know that social factors can drive health inequalities. We know that there are biological factors and genetic factors that can drive inequality. There are communication issues. There are kind of personal health behaviours, whether that's smoking, drinking, inactivity, etc. And then we know that there are also some issues about the quality of access to generic and specialist healthcare services. So we know that there are 5 key determinant areas. So what we've done is to draw out from the evidence base specific indicators against each of those determinants, and to find a way of measuring an individual's exposure to each of those determinants. what we've done is we've come up with I suppose, a relatively simple software solution. From the outset of this project, what we wanted to do was to develop something that was essentially free. It's not a thing that we sell, it's a thing we wanted to put together and give away. We also didn't want people to have to rush off and invest lots of money in licenses for expensive databases. We had this kind of dilemma early on about, are we looking for some sort of really snazzy, glossy, sort of interactive, web-based sort of database system, which is going to cost a huge sum of money? Are we going to build something on Microsoft Access? Are we going to look at Excel, which is kind of a spreadsheet? And we sort of struck a compromise. We recognised that if we were looking to develop something for all workplaces, so not just big NHS trusts, but for small providers, for families at home, lots of people don't have a software licence for Microsoft Access, so for the database. So we had to go with Microsoft Excel. We managed to get a little bit of money to invest in this. It was only a very small amount. So we managed to get some really clever software developers to work with Excel, so with a spreadsheet. And they tell us that they did really clever things and developed some innovative ways of coding, whatever that means, that essentially kind of makes Microsoft Excel behave much more like a database. So it'll handle the sort of data and the analysis that we want. But I suppose what we've compromised is that we don't have the snazzy interactive graphics that you might associate more with a database. Yeah, we wanted something that would allow data to be inputted quickly and easily by nurses. Nurses that were involved in the pilot work tell us that it takes around about 20 minutes to profile one of their service users once they've done it a couple of times. And we also wanted something that would be easy in terms of doing the data analysis, and we'll show you that in a minute. I've already mentioned the 5 determinants. I'm not going to go through them again. So obviously the other thing that we wanted, I've already mentioned, is not just to be able to look at individual service users, but also to be able to look at what goes on for people at a much broader kind of population level. So there had to be this ability to both aggregate and disaggregate data, so that we can look at individuals or we can look at populations. And Gwen's now, I think, if I remember the order of the slides, going to give you a performance. Yeah. Oh, there you go. Right, go on. You can talk.
I'm going to talk first before the non-existent video. Okay. So we thought that the best way to tell you about the HEF is to give you a case study. And those of you who've seen us present before will know that we do try and use case studies. But this one is a new case study that we haven't used before. And what we were hoping to do was to show you 2 video clips of Sam's mum talking about not the HEF, but about Sam and what Sam's like and about the problems that he experiences, and about how the intervention the nurse has made a difference. And then we're going to put with it, we're going to show you what the HEF looks like in relation to that. So when the black screen comes up, pretend that the mum's on there, and I'll tell you a bit about her and about Sam. So he was referred to the learning disabilities team following repeated periods of ill health and frequent hospital admissions. Sam is a young man of 24, and he's got really profound learning disabilities and quite a lot of complex needs. And when he goes to hospital, it is actually life-threatening. He's the sort of young man that could easily have appeared in the confidential inquiry. When the nurse assessed him, between us when we assessed him, we found that there were some real concerns about how difficult it was for him to access good health care, in particular in the hospital, but also with his GP and primary care. And it was very difficult for anybody to identify if he was in pain or to know when he was going to become unwell. So he becomes unwell quite quickly, and very quickly goes from being well and not needing any intervention to being in hospital and to being on life support technology, so very, very quickly. And there weren't any known warning signs to actually prepare people. So what we were interested in looking at was, is there a way of finding out what precedes an illness, or how we can tell if he might be in pain? So that was something we're very interested in. Sam's mum is now going to describe some of the issues in the following video clip, which I can't do. Oh, there it is. You never know, it might work. Okay, so obviously you can hear her talking. It's a real shame because we even had music on the video. But, you know, in keeping with Helen's singing this morning. So basically, he's a 24-year-old young man. He's very, very small. He's about the size of an 8-year-old. And because he's very small, people think, when he goes to hospital, people think that he should be treated like a child. So the first thing that happens is in the emergency department is they say, well, we can't deal with him, we'll have to call paediatrics. So there's a long, long delay while paediatrics are called. Of course, none of the equipment fits him. If he needs a nebulizer, the adult nebulizer won't fit. His face is too small for it. If he needs oxygen, so you can imagine all the different things he might need. If he needs a cannula, you can't use an adult cannula on him. So there are some real reasons why the medical staff in the emergency department might feel that he needed a paediatric intervention. They always feel they need to admit him because when he's not well, he vomits and he becomes dehydrated very, very quickly. He's got a peg fitted, but obviously if you're vomiting, you can't keep your hydration up. So he becomes dehydrated very quickly, and of course that becomes a real issue. He suffers from quite serious chest infections, and he's got a spinal rod fitted because when he was younger there's some real problems around posture, so they fitted a spinal rod which has got its own set of issues for him. At the time when we assessed him, he didn't have any sort of sleep system in place or anything really to improve his comfort either. So that's what Mum's just told you. Still. So this is the HEF score at the time. So we looked at, when we did the HEF, you can see by looking at this that the major issues there around his ability to communicate his pain and his awareness of pain, some issues around the genetic areas of genetic and biological areas. And if you look at the next slide, you can see how this is broken down. So immediately you can see that in the genetic area there were no crisis or hospital plans in place. Very little assessment had been done. There were issues around clinical review as well. Nobody was really reviewing his care. They were living from one crisis to the next. You can also see that because of his physical disabilities, exercise was quite an issue for him. He couldn't possibly take the amount of exercise that the HEF looks at as being a healthy area. But here you are, you can see why we've got that big peak on the communication bit. You can see that all these areas are actually serious issues for him. And actually service quality, there were issues as well around service quality and his ability to access service quality. So what I've just described is reflected in the HEF. The very good thing about the HEF, and for those of you who are a little bit technologically phobic, like me, is when they started to create it, we did actually say it's got to be something that Gwen can work. So if I could work it, so can everybody else. That was kind of the theory. And but what I love about it is you don't have to do this; it does it for you. So if you look at that, I think, she produced those lovely charts. No, the HEF did that for us. So the very clever technology that our colleagues from Smart Outcomes created does this for us. So what did we do then? So the first thing we did was we actually made sure that he'd got an up-to-date health action plan and health passport for when he goes in and out of hospital. And you'd think for someone like Sam that would just be a given, that would be there, but it wasn't. And so that was the first thing. And because the GP, invariably when the family went to visit the GP with Sam's always very, very ill, the GP didn't see any real need to do any other health check with him because he felt he saw a lot of him anyway. So there was a bit of an issue there about there not having been a proper annual health check, although I'm sure the GP recorded him as having done one because he'd seen him enough times to feel that he was up to date with all his needs. One of the things we've been working on in our area is something called a pain picture or pain profile, and it's designed to help, it was originally designed to help medical staff know when someone's in pain if they can't tell you. And it's basically a pain picture that's developed with the family carers and other people that know the person really well, and the person, if they can contribute any information, based around common signs and symptoms of pain. So it looks at things like colour, sweating, groaning, whine, all those sorts of things that we know are pain indicators. And so what it does is it identifies how the person is when they're not in pain and what people have observed when they are in pain. And in Sam's case, there were some very specific things, actually, that the family were able to say, oh, actually, when he's in pain, for example, his skin goes almost translucent. You can see the veins underneath. Now, that means that somebody treating him, if they see him with a translucent skin, will think, oh, maybe there's some pain, perhaps we need to give some pain relief. But more importantly, maybe he's also going downhill and there's other health problems about to happen and we need to be aware of that. And staff in the hospital followed a pathway to make reasonable adjustments to improve the care that they provide for him and the assessment and treatment that they give. So we were able to work with the staff in the hospital to actually ask if, when he comes to hospital, he could have a named consultant. This was very important to the family, who felt that from childhood he'd had a paediatrician and then he hit 19 and that all stopped and nobody would take responsibility for his care. So he had all these different people involved with him. He's got about 6 or 7 consultants that look at different things and none of them talk to each other about anything. And Mum wanted somebody to be a named consultant, so we managed to persuade one of the consultants to take on that role. And we also had a named nurse in the ward that he regularly goes to and asked for him to always go to that ward unless there was a real issue why he couldn't go there. And the consultant wrote a letter to go in his notes in the emergency department, which, I don't know if this happens in your hospitals, but the emergency department keeps separate notes to the main notes that go into the wards. So it was really important that they had those notes in the emergency department. So there's notes there that say, if he comes in, he's under me, I want him admitted immediately to X ward, so that it cut down on the waiting times. Mum talks in the video about being made to wait for 12 hours before anybody did anything. So that was a big change. So now if he has to go to hospital, he's treated very quickly. He doesn't have to go through the palaver of being referred to paediatrics to then be told, no, he's over 19, we won't deal with him, you've got to go back to adult services. And then Mum talks about being made to feel that somehow they were doing her a favour, looking after him, and also that he was being kept alive and he had no quality of life. And of course Mum talks a lot about who he is and what he's like as a person and how he's a very happy person and, you know, how when he's not well, what he's like as a person. So the other thing that happened is that as a result of the pain picture, Mum found it changed the way that she perceives his pain. So in this next video clip, Mum's going to explain how that made a difference. See, I'm using the technology here as well as I can. So what happened is that actually she, by giving us the information to put together the pain picture, and we created this checklist, it made her think very differently about what they do as a family in terms of checking when he might be in pain, thinking about when they might need to get help and when not to, when he might need to go to hospital. And she said that when you're in a panic and your son is ill and your other 5 children need, and this lady's got 5 other children, and they all need you to do things for them as well, you can react very quickly to that situation and be very anxious. And then you can't think about what the best thing to do is. But having something like the pain pictures helped her to be quite structured, the whole family to say, well, is that the case? Yes, it is, even though the information came from them. And she says it's reduced dramatically the number of hospital admissions he's had in the last year, which wasn't something we thought was going to happen from the pain picture. Now, Dave is actually going to, we're going to do a bit of live data thing now, aren't we? One hopes. This is the other bit of the technology. So we did, you saw the before, so we're now going to do the after. I've got one I prepared earlier in front of me, fortunately, on a bit of paper. So you'll remember how he looked before. Dave, I think, have you got the version with the original on it? Yeah. Good. That's a good sign. And for speed. So what we're going to do now is we're going to open up the eHEF. Now, have many of you seen the eHEF, actually gone into a computer and seen it? Okay, well, this is what it looks like. So when you go into the computer, this is how it looks. And Dave is going to press buttons, aren't you? So if you have a look, there's a pointer thing, isn't there? Now, hang on, which thing points? That. Okay. Oh! I've got used to technology, as you can tell. Okay, so if you have a look up the top here, can you see it says options? Yeah?
Right, Gwen, I'm wired for sound.
You're wired for sound. Okay, you can talk about it. I'm going to let Dave tell you.
Right, so we just need to enable it.
So that enables it. That's why I was pointing at the options. Right, go on.
So you would log in, obviously if you were using this for your own team, you would have a team profile and you'd have individual user profiles.
Can you just show people how they'd create a new user? Because it's actually so simple, I think it might make people feel...
Stick some initials in basically, and then it asks you for a team name, so it's very quick.
So you probably need to log in as me.
Right, we're in. So what we can do, should we initially, we'll have a look at Sam's data. So if we have a look at his existing profile, if we were registering a new user, we'd be using pretty much the same profile. So you can see sort of scanning down from the top, you know, we've kind of got usual sort of identifier numbers, so NHS number, and then whatever local sort of systems are in use. We have codes for the member of staff, the team, then we have the service user's name. Then we have some biographical details, so gender, ethnicity, age, etc. We have postcodes, which at this stage aren't used for a great deal, but I'd like to think that one day in a large-scale aggregated model we could draw out deprivation codes for local areas, which will give us much more powerful data. Then we just have a profile of needs, so you can see a range of things there: mental health issues, challenging behaviour, autism, respiratory problems, etc. And you can see those areas selected, which in Sam's case were pertinent. We're not asking for really precise clinical diagnoses here. We're asking for a reasonable professional judgment as to where an individual's presenting needs are. So I'll close that down. We're not going to alter anything on there. So that's Sam. He's already on there. Let me just go back a level. What we can then do is we'll have a look at how we would enter a new profile. So if we wanted to enter a new set, I'll use the edit scores. So we'll look at Sam's last set of scores. Shorthand. So we'll have a look at the follow-up score, Gwen, which was the first score.
You're going to do the follow-up score.
Okey-dokey. There we go. So that's the sheet that we would use to input data. So again, a bit of biographical stuff across the top. We've got date. Evidence for practice is a separate supplementary tool, which I'm not sure we've got time for today, but which is a way essentially of logging what it is that a nurse or a team have done. We keep track of how much support an individual's got, whether that's fluctuating over time. We can also, in this box here, we can enter any comments. So if since our last score there's been a bereavement in the family, someone's changed residence, whatever, just to provide context when we're looking at the subsequent profiles, it just helps to inform us. We then have these, I gather they're called radio buttons. So we click on these as we select the appropriate score, and you'll see over on the right hand side we have the indicator which pops up here to guide us in choosing the appropriate score. In the box below we have a slightly lengthier description. So you can see running across here we've got social, genetic, biological, communication, etc. So they're the 5 determinant areas of health inequalities, and then running down below we have each of the individual indicators. So to reprofile, and don't worry Gwen, I won't save these changes, it's literally a case of going through the boxes in that kind of a fashion. So I shall cancel that. We'll then go to, no, you've already shown his profile, haven't you, Gwen?
Done that, so do new scores.
Okie dokie, so we'll have a look at how we would put some new scores in for Sam. Gwen, give me some rationale. Let's think about social then in the first instance.
Okay.
So I know that A refers to accommodation.
So he's in settled accommodation, and we believe that although he can't actually say by the way that he reacts with his family that he's very happy to live at home with his family. So I think that is a 1.
So we score him at a 1 there, which is obviously the lowest level. Green is good, red is a bad situation to be in. And for B, which relates
he's the
to
one again
engagement.
in B. He's got quite a lot of disability, but he goes through an extremely good service during the day where he gets fantastic support and care. It's a very comprehensive service. It includes all sorts of activities like hydrotherapy. It's got a mix of health and social care activity for him. So I think
we'll go for a score of 1. So then we come to C, which is about a person's financial supports.
Yeah, when, well, I didn't mention it earlier, but when we first started working with Sam, there were some real issues about his personal health budget, and Dad, which they were on the personal health budget pilot, and Dad was in the process of writing all sorts of very copious letters to the then PCT. His dad's an accountant, which does help, and now that's much more stable, so he's a one now on that as well.
That's an accountant, it's going to be pretty low.
That's an accountant, does help.
Okay, so then we go to D, which is the fourth of the indicators within the social domain. So this is about how socially connected an individual is.
And actually, he is quite socially connected. His mum, again, on not on the video clip I was going to show you, but on the longer video that we originally made, talks a lot about when she goes out. Sam knows so many people. They come up and say, "Hello, Sam, how are you? Lovely to see you." People who've met him in other places. And he's a very engaging young man. So he seems to attract people to him. He has a quality that makes people feel comfortable with him.
What score do you think, Gwen?
So I think he's a 1 on social.
Got him at 1. If I can find the mouse button.
And I've got him as a 1 for marginalisation, and the reason for that is that the reason the marginalisation was high originally was because of the physical health problems he had, and I think because of the interventions that we've made, they have reduced.
Just to show the contrast, very high scores for sort of marginalisation would be where there are other factors that influence a person's quality of life, and in particular we might think of ethnicity, sexuality, gender, etc., those sorts of issues. So for this chat, I think you said 1, Gwen.
Yeah.
If we then come on to F, so then that's just overall sort of
0.
safeguarding.
Safeguarding is 0 for him. There's no safeguarding concerns.
Excellent. Gwen, I'm thinking in view of time, rather than go through the whole profile, people have seen us do one domain, so if we skip to the
one we saved, we have one we prepared earlier.
Yes, absolutely. We'll do Blue Peter next time. With me, just 1 second. So we go to the most recent, 15th of September, it's pretty current. We'll click on edit. So there you can see the full range of scores across each of the 5 domains for this chart. Shall I go next to the graph and we'll show both for the purposes of comparison, Gwen?
Yep.
Absolutely. So then we go to, so we've got lots of scores in for our chat. We could reprofile him every 3 months or every week, or when the case is referred to us, when the case is closed. We could do it in relation to CPA reviews for some individuals, as we like. So to generate a profile, see what it looks like, we can compare Sam in March with Sam in September. We graph it up. There you go, you get a nice visual image. So the blue scores were the starting point back in March. The red scores relate to the 15th of September. Essentially, the nearer the centre, the nearer the green, the better a person's situation is. What we're very clear about is that if we reduce exposure to the determinants of health inequality, it doesn't mean people are cured of all their health problems. What it means is that they're no likely to experience adverse health outcomes than an equivalent person with similar conditions who didn't have a learning disability. So the closer to the green we can get people, the more we've reduced the health inequalities. And of course, people sometimes ask us about the validity of this, and the validity really is drawn from the quality of the research which the Public Health Observatory provided, which underpins this. So we're pretty confident about the rigour of that. If we scroll, obviously you can see there we could print out paper copies. We're aware that if this is being used in a family home or if it's a small-scale service, there may not be the same access to electronic patient records, etc. So paper copies and paper records may still be in use. We can then scroll down the rest of the page, or maybe we can't. Yes, we can. And we can see for each of those 5 determinants, again, the kind of before and after scores. So we can see that for Sam, over the intervening 6 months, that his accommodation situation had improved, his financial situation had improved, he was less marginalised. If we look at the genetic, we can see that he's had some good assessment work that's gone on, more effective reviewing processes, care planning, and in particular, and I guess significantly, some work's been done around planning for crisis and emergency hospital admissions. Scroll down a bit further. For his behavioural issues, relatively little, I guess, has changed, except that he now seems to be more physically active. The score is going towards 0, so he's not as inactive as he previously was. For communication, we can see that across really each of the 5 different indicators linked to communication, that the situation's improved. Now again, this is the kind of the real world within which we work and the outcomes which we therefore want to monitor. Whilst the communication scores have increased, that's largely reliant on the quality of the support and care plans that have been placed around SAM, and in particular, in my view, to some of the work that was done around the pain pictures and pain profiles. And then finally, we can move on and see the service quality. So issues to do with transitions, screening and health promotion, again, significant gains. I guess what a lot of our nurses have told us through the pilot exercise is when they generate the initial profile, so if you like the blue, that when they look across the whole profile of their service user, it starts to inform decisions around health action planning and starts to help them to prioritise which areas should be targeted in order to maximise reduction to in terms of the exposure to determinants of health inequality.
The other thing it does is it enables you to think about who's intervening, whether you should be asking somebody else to get involved. So for example, if you had a lot of 4s and 3s, for example, in the social part of somebody's screen, and they've got no social worker, it's actually quite good evidence that you can use to support why you'd make a referral to a social worker and why that's important. And, you know, you've actually got something concrete that you can show to somebody. And I do know in our service, where we have social workers working in the team as well, we've started using the HEF across the whole team. But the nurses have found it in particular, because they've been using it longer, they found it very helpful to actually engage with people who are saying, well, I don't really think that's an appropriate one for me, you're working with them already. And I think if you see particular issues around communication, so that might help you in terms of getting speech and language therapy. And as a service, it might help the service explore why they might need more nurses or why they might need less psychiatrists. I didn't say that. So anybody who heard me talk yesterday, I talked about psychologists, so today I'll have a go at psychiatrists to make it a bit more even.
Gwen, I'm going to flick back to the PowerPoint presentation if we can.
Yeah, you do that one, yeah. So,
use your clicker.
Yeah, there's only one more slide anyway, Dave. So it's really important to recognise the values this might have in helping you to think about what you're doing with your caseload and with individuals, and for other people to do that as well.
You need to use your clicker.
I will, but there's only one slide left. So there you go. So this is for you, Dave.
How's it? Okay, I'll stick to using this. So you've kind of seen the HEF. Unfortunately, it's not the same without Mum's description.
Real shame.
There's some real kind of power in her voice, and it really, I think, helps people to understand these are the sorts of people that we all as learning disability nurses work with all the time. So if we start thinking about the application of the health equalities framework, I'm going to try and rush because we might have time for a question or two before people come and join us. How in practical terms might you use this? Well, kind of imagine teams of nurses, whether they're working in houses, on wards, in community teams, whatever, each with access to a shared spreadsheet for their service users, each logging and profiling on a regular basis. Some of the suggestions that we have come up in the discussions as we've consulted have included things like triage assessments. So I used to work within a health facilitation team. If I was to go back to that team today, I might very well think about, should we be looking at doing this kind of profile at the point of referral, and would that help to inform those decisions about prioritisation? We can look clearly at pre and post intervention. So, if someone's referred to the team, we do a piece of work, we then profile and measure and can demonstrate the outcomes afterwards. Caseload allocations, again, I was talking with a colleague just a couple of days ago, linked really with the sort of triage notion. So if we profile someone within a couple of days of referral, if I then can see that the aggregated profile of areas of need that the nurses on my team are working with, then that might help me to make decisions about who best to allocate that service user to. So into that kind of overall sort of team caseload, I can pick out the specialists in relation to sort of different areas of working. Longer term monitoring, so if we imagine sort of services potentially where people live for a long period of time, so you can kind of envisage doing a HEF profile perhaps at 3 monthly or at 6 monthly intervals, perhaps linked with CPA reviews for some individuals. I've already talked about the notion that it could help to inform health action planning, and already again during sort of consultation, some people have suggested that traditional health action plans focus on needs related to health conditions, and that maybe we could reconstruct some some health action plans to include actions in relation to each of the 5 determinant areas. So we're kind of working proactively rather than waiting for significant need states to develop. We can start, if we start thinking about aggregated data, we can compare outcomes of one team versus another team, or one model of working versus another model, so that collectively as a professional group and across large sort of areas, we can understand the differential gains that are associated with different ways of working. It can start to inform strategic needs analysis, the self-assessment framework, health and social self-assessment framework that was just, I think the guidance was just published a couple of days ago, is already suggesting that HEF data might be a really sort of powerful way of informing sort of local strategic planners about the direction that services are moving in. So it supports that kind of local needs analysis model. Certainly informs commissioners, I mentioned that a little bit in the introduction, but if as a commissioner I commission lots of different types and models of service, I can again understand those that deliver the greatest outcomes. It's very empowering to service users and to family carers, and the notion certainly picked up by some family carers. Some relatives have told us that they would really like to use this, that when their son or daughter moves from one service to another, they would actually like to use this to profile and to gauge for themselves whether we and our decisions are to the benefit of their relative.
Say, part of our consultation, we met with the Value in Families Forum, yes, them, and they are a very, very feisty group of mums, and
scary people,
quite terrifying actually, and much more scary than Royal College of Psychiatrists, who we also met with. Luckily for us, they did like the HEF when we talked about it, but what they said to us is, actually, you've got the name wrong, and we said, oh dear, what do you suggest? And they said, we think you should call it the common sense kick up the backside tool.
It wasn't really, it was the common sense kick up the arse.
Yeah, I know, I was being polite. So that's what they said.
And that's kind of about it. We could talk about this stuff for hours, but I'm hoping that perhaps if anybody wants to ask a couple of quick questions, that we've just got a bit of time. No one does.
Thank you very much. I'm sorry about the video.